Good morning, everyone. My name is Roisin.
Hello, I'm Emma Jane.
And actually, we have to update Emma as the new clinical specialist, actually, in occupational therapy in St James's Hospital as well. I'm delighted to be here today to present, I suppose, what physiotherapists can help with in terms of helping to manage as part of the multidisciplinary team. And that collaboration is so important, and I'm going to talk a little bit about kind of, I suppose, how we work together and how one person on their own really isn't going to support that person. And again, I suppose we are at the outset, and people may have experienced times where they felt their physiotherapist didn't understand this condition as well. And I'm hoping that somewhere along the way, myself and Emma and others are going to be able to kind of help to kind of grow that knowledge in Ireland, and that's one of kind of my big passions in life now. So what is physiotherapy aimed at? So I often call physios spend so much time with patients. You know, a lot of the time doctors are in and out, and physios and OTs, we actually end up kind of spending that 45, we know everything about their lives, we kind of get that bit more time to chat and support because our sessions tend to continue on. So that bit of psychologically minded physio is kind of where we're kind of as a starting point. And we're also very good, I suppose, at the neurological assessment, and movement is what our bread and butter is, and how the body moves and kind of understanding that. So we use the assessment and that part of kind of unpicking to be part of how we treat people. And then the education, again, because we spend that time with patients, we can often, the first thing I'll say is, okay, what has your neurologist said to you? Okay, where are we at for that starting point? And I'll try and unpick those bits where maybe things were picked up in a way that wasn't that wasn't, I suppose, communicated very well, or it might be that I'll help to kind of garner the understanding through movement and assessment to help the education piece. We use those positive signs that Aoife talked about, and that is a real way into treatment. And it's not ever a kind of like, aha, I caught you out, I can see that that's moving. It's a real kind of like, that's amazing, look what your body can do when we're using those automatic pathways. Let's try and figure out ways that we can use that in other parts of your life. And movement retraining, you know, whether we're looking at, I always am trying to find what that passion is for a person, because if you're doing something you love, your body will always be more natural and move. I say to people, like, when you're walking, when you're moving, you never think about what your body does. I'm thinking about what's on my phone, I'm thinking about what I'm eating in the fridge. My body doesn't think about how I step forward, and if we can tap into that component, it will help to retrain movement. And then how we help people to self-manage themselves, and that can be really, really important. So I'm going to go through some of those. This is a slide by my colleague Sarah. So myself and Sarah, Sarah works in psychology in Beaumont, and I often try and help, I suppose, in that early education piece to think of these bubbles. And this is the person that has all these bubbles going on, kind of due to this combination of sometimes a massive big biological bubble where some trigger has been a really clear, you know, injury event, to fall off something that triggered off these sensory or pins and needles or different types of symptoms. Sometimes there can be a bigger psychological bubble, sometimes there can be a bigger social bubble that's going on. And what we try and do is, I suppose, I try and work the best with the components, but I have to then bring in my colleagues and know, okay, well, maybe this isn't the best step for you at this moment in time. Maybe another colleague of mine is the person that will work at that starting point, and then I will come in and support. But I think back kind of where Aoife kind of began with, there was a kind of a theory at one stage that physio was just a supportive role in managing FND, but actually I now see myself as a real primary role, which is great. I would have thought, well, okay, maybe psychology first and then maybe physio, but actually with a really well communicated diagnosis and support from someone, physio or OT, often we can unpick those movements and support someone to function so much better, and that can be kind of what's needed. So how do we do this? So some of it is about, Aoife showed that really original video, so I'm just going to use the example of functional tremor, where someone is experiencing that tremor, and we saw when there was a distraction how you could dampen that down. So if we try and use things like, if someone is using that tremor and I'm asking them to make the tremor bigger and then make the tremor smaller and slow it down, I can kind of tap in ways, and I often use a video of the person showing them how their brain is able to dampen down movement or increase movement, and ways that they can help to, I suppose, control those symptoms in certain scenarios. Things like progressive muscular relaxation, focusing on the parts of their body can help. And these are just strategies to support the person. And I do the same thing in gait, do the same thing for lots of different areas of motor problems. Glenn Nielsen is a bit like John Stone, so he's the guru that we talk about from the physio point of view, and I absolutely love his kind of way of explaining FND for patients, and this is kind of how I suppose I go about it, and I'm just going to talk through that just briefly, because often there is a triggering event, and not always, but it can be something like that injury or illness or reaction to a medication, and it's different for everyone, but that novel, new onset of symptoms can trigger off, I suppose, pain, pins and needles, numbness, and something that, you know, that is kind of out of the person's control, and the fight or flight system can kick in that scenario. So example would be a fall and you get sudden pins and needles. There may be some background stress and anxiety, the ones that we all experience, and it can be over kind of a very busy period in work or different things, but it's that turning the brain's attention towards it that can happen in kind of a brain processing of the sensory and motor information. When the body turns the attention towards, like Aoife was talking about, in a very tense way, we're kind of scanning and looking for danger. And then that can impair how the body moves. And what we talked about along, all movement should be automatic, so we don't think about how we step, we don't think about how we move. But I like the example of choking in sport. I always think I have a picture of Johnny Sexton going for that kick of the ball, and you can see him visualising. If he stopped for a minute and went, okay, I'm going to kick that ball right there to the left and my foot's going to land in it in that moment, he'd choke. So I use those type of analogies to support the person kind of understanding why that freeze might occur and why the brain will stop that event. And then there can be that expectation, like Aoife talked about, that the brain starts to expect this unwanted movement, and then things like self-focus, which we'll talk about, and brain expectation can drive it, and that then can lead into disability. And it is over time secondary changes. If I hold my body in a certain way, I'll get aches and pains, and all of that becomes a vicious cycle that will increase, I suppose, how the function is impacted. So understanding that, I suppose, helping with the education around that, but then finding the ways that we can show how those automatic movements help. And the Hoover sign that Aoife spoke about, this is again a really nice way that I can get someone to kind of, again, videoing is really nice, and kind of unpick, right, well, you were able to activate those muscles in your bum. And I often say to someone, when we walk, it's actually the standing bit that's the really hard bit, so just activating it up. It's not actually the swinging part of your leg that is the hard part when you're moving to walk. So if I can say, right, I've seen how that muscle kicks in during the Hoover sign, let's try and activate that. And it might be that when I'm asking someone to do it, the more I ask them, the less it's going to happen. So then we bring in all the different kind of tools that we have for movement retraining. How do we explore movement and their symptoms? How do we kind of, I suppose, unpick the bad patterns? Because I ask someone, you know, if someone has been walking with a leg dragging for a long time, it's going to cause all these types of aches and pains throughout the body. And if you try and do that, you will not be able to do it. So we're trying to figure out how to unpick the normal patterns of movement. Developing strategies, so thinking about different movements, thinking about fast movement, unrhythmical. I'll often have patients trying to run, and they're like, I can't walk, what are you talking about trying to run? And that might be something as the journey goes on, but running, and people will talk about treadmill training, actually there's quite an automaticity on that. Walking backwards is something, so when I walk backwards, I don't have a structured pattern or brain of how I do that. It kind of happens much more automatically than walking forwards. So those type of patterns, and like I had a patient who was like, okay, I can walk backwards, but what help is that for me for life? I have to be able to walk forwards. I was like, it'll come. And finding ways like things like sliding, or like I'll put slidey things under someone's feet in order to kind of start the process of movement, rather than just thinking about that I have to be able to step one foot forward in front of the other. Visual feedback can be really good, and that's why kind of videos often will show us kind of before and afterwards what's working well and what's not working well. And changing those maladaptive compensatory patterns that are happening, because if you're in pain, it's going to be so much harder to try and feel like you can take those steps forward. Graded exposure to functional goals. So this is, again, you know, it's so hard in physio. People often go, oh God, I can't do 10 reps of that exercise every day. It's so boring. And like, what's my goal? What am I aiming towards? And if someone doesn't have that kind of specific target, what they're aiming for, it's very hard to improve. So from the day-to-day, and I'm trying to, I suppose, unpick what a normal day looks like. And it might be as simple when someone is, for example, in hospital with, okay, how long does it take you to put on your shoe? Can we set you a goal of doing that, you know, 20 seconds quicker? And that's as simple as it is, rather than it being kind of big, massive goals. So we pick it into the small little bits. Involving the family in the process of goal setting is so important, or someone's key people in their lives, and that will really help to kind of have a driven kind of plan together. If it's just a person on their own, they tend to need that kind of support network around it. So even something like this is called a goal attainment scale, and it actually gives a scoring of kind of what we would expect from an outcome, and it allows someone to kind of exceed or have a lesser outcome for it, because we know that the journey with FND is never just like this. Okay, I often say to patients, the journey is just going to be, we might make some gains, but the goal is that each time the dip isn't as much, and we can continue to kind of progress forward. So if you have something structured around goal setting, it can be really helpful. Aids and appliances, again, really love what Miriam was saying about this, because this is a really important thing, and I often use these to kind of support the steps through improvement. And I'll say to someone, listen, we're going to use these crutches for the weekend because I want you to be able to get out, and if they were in hospital during the week, and I want to be able to go to the bathroom, I want you to be able to do these things, and we'll aim to see kind of next week, can we move to the next form, kind of having that next goal of form of aid. But again, in the longer term, and the longer looking at this, I'm always like, what do you want to be able to do? It's not about how you do it. What in life will allow you to function well? And if that is a wheelchair, if that is a form of mobility aid, then that's going to get you to be able to explore life, rather than the world getting smaller and smaller and you staying at home and not being able to engage in things. If we can use those aids, we're going to support you. I suppose what also can happen is we want to try, I suppose, maximize, as a physio, I'm always like, but how can we get movement? So we want to use that at times where necessary, and then kind of support mobility where possible. And it's not just, I suppose, what happens a lot is then things can be all put down to FND, and it can be, you go to see a doctor and you've got a pain in your shoulder, and they're like, oh well, you've got FND, so it's related to that. And I'm like, okay, well, other things can happen to people. It's not just all connected to this. So a physiotherapist's goal is also around muscles, joints, nerves, understanding how that impacts on the person's function, and trying to, I suppose, unpick those things rather than putting everything down to one condition. I found that really important. This could actually jump into, if anyone, Reactive PT is a really lovely website or it's an Instagram that talks about it. If it does start playing loud music, just be aware that happens. But there's loads of different types of innovative sensory ways. You know, there's lots of stuff around heavy work, pushing, pulling, things that really kind of upregulate your system that can be really helpful. I like this. If this plays, let me see. Oh no. Let me see. Oh no, it didn't. Sorry. What that's happening there is someone has their hand on a treadmill, and they're basically moving in and out. Lines are drawn on the treadmill, and the person has to move in and out. So someone who has difficulty with sensory feeling on their hands, and kind of doing something that kind of provides the feedback and provides lots of different sensory goals and something to achieve as you're doing it. There's loads of different kind of examples and things of this that will allow it. I've got some of these different light pods that it's kind of like working to try and unpick how the body moves in with sensory drive, kind of helping to support it. There's lots of different ways. You know, if we're talking about different devices, functional electrical stimulation, de-weighting. These are all things that we might use for periods to get that function going. And from my point of view, again, recovery and self-management, my goal is never necessarily, I say to patients, I'm not here to necessarily fix those symptoms. I just want to see how you can function better. And as time goes on, if that symptom reduces and becomes smaller and smaller, that's brilliant. But really, what I'm asking for you here is how can you live really, really well? And I think Emma's going to talk about this as well, about setback plans, and this is just something I found really nice on fndcourage.org, talking about kind of when you're seeing a physio or when you're seeing a health professional, it can feel very much like, okay, well, they've told me that's the end of the sessions, and I really try, one of my things is I try and bring people back at, you know, if I'm finishing, I'll say, right, well, I'll bring you back at 3 months and just make sure, or we'll connect back in at 6 months to see if things are in kind, support them. But having a setback plan is so important, and that you and your family are on the same page with that setback plan, whether it be what happens for medical emergencies or whether it be kind of how you manage those. Again, like Miriam was talking about, what are your friends' strategies if you do have a non-epileptic event and you're there kind of wondering kind of how will I cope with that? If you have that structured out, I think physios and OTs can be really helpful in kind of supporting that. So I'm going to hand over to Emma for the second part.
Hello, I'm Emma Jane. So I'm Emma Jane, I'm one of the occupational therapists. I'm currently working in St James's Hospital. So when we think about what is occupational therapy, so occupational therapy helps people live as fully and independently as possible. So if you're dealing with illness, disability or challenging life circumstances, an occupational therapist can work with you to manage your daily activities. So things like taking care of yourself, getting around, working and enjoying hobbies or interests. So we work with you to find out practical ways to do the things that matter most to you. So our occupations are the activities that fill our days and give our life meaning and purpose. And occupational therapists understand how important these activities are to each individual person. So we're experts in helping you live as fully an independent life as possible and to do the things that matter most to you. So the occupational therapy role in FND, so we're dual trained in physical and mental health skills. So Aoife mentioned having that bridge between neurology and psychiatry, and I'd like to think that OTs may be sitting on that bridge and fishing probably, bridging the gap between the two. So OT's role is to identify and address the impact of FND symptoms on a person's ability to live their life. So we'll assess how your condition affects your everyday activities, and this includes things like, you know, getting around, transferring, doing household tasks, preparing meals, getting out into the community, working, as well as social and leisure activities. So we see every person as an individual, but we'll likely break things down into self-care, productivity and leisure tasks. So FND can look very different for each person, and there's some common areas that it tends to affect. So when we think about movement, we'll work very closely with our physiotherapy colleagues, so movement symptoms like weakness, shaking or tremor, and difficulty walking. Thinking and memory, so FND can make it harder to concentrate or make it more difficult to remember things or to stay focused. So occupational therapists can work with you to build cognitive strategies to help do your daily activities despite these symptoms. So visual symptoms, so things like blurred vision and double vision might impact your ability to read or watch TV, or even practical things like crossing the road. So fatigue and pain are often co-occurring in functional neurological disorder, and OTs can work with you to help manage those symptoms, which might help your other symptoms as well. We can help come up with a plan to avoid kind of boom bust cycles, which can be common in FND. So overall you have a more even kilter to do the things that matter most to you. So in terms of mood, we'll work closely with our psychology colleagues. So I suppose even living with the symptoms of FND can have an impact on your mood, and occupational therapists are there to help with emotional regulation strategies and to help to explore that as well. Dissociative seizures is also a common symptoms found in FND. Speech and communications, so speech and language therapists will take the lead on this, but we'll work with you to incorporate those strategies into your daily activities. So sensations, so sensory loss or reduced sensation, many people with FND report hypersensitivity, and I'll explore that a bit later on in the slides. So an initial assessment with an occupational therapist. So we're going to ask all about you, break down your occupations into self-care, productivity and leisure. We'll explore a typical day and what life was like for you before symptom onset. We'll explore the impact of your symptoms over a 24-hour period and maybe establish any patterns in your symptoms. We're going to ask what matters most to you, so your life roles, your social connections and your interests. And we might assess you completing meaningful activities to explore how your symptoms might be impacting your performance. We'll help with goal setting with you in conjunction with the wider MDT, multidisciplinary team, which will help inform the focus of our treatment. So how OT can help. So every person is different and your therapy will be tailored to your individual needs, and it's based on what we learn in the assessment with you. But OTs might work on breaking down tasks into more smaller manageable steps to help you to do them more easily, setting goals together that help you become more independent and reduce the amount of support that you need. Using everyday activities as distraction, which can help improve movement, as Roisin has touched on. Helping build confidence, motivation and a sense of achievement by doing activities that are most meaningful to you. Bringing together your progress and what you've learned in physiotherapy sessions and psychological therapies and using it in your daily life. So what have you learned in physio and in psychology, and how are we going to apply it practically? Supporting you to pace your activities so you don't overdo it on the good days or crash on the bad days, and helping you build a routine that supports roles in your life. We also support with sensory processing, so that's how the mind and the body takes in, processes and responds to sensory information. So sensory processing, everyone has sensory processing needs and preferences. So I personally am a sensory seeker. I currently work in the emergency department, so I love that sensation, all the stimulation, the fast pace, and for someone else that's their worst nightmare. And it's not bad, it's just different. So some people with functional neurological disorder have sensory processing differences, differences in identifying their emotions, which is called alexithymia, or differences in recognizing bodily signals, which is interoception. So self-regulation strategies is one technique that can be used to support with sensory processing. And an occupational therapist can work with people to identify their sensory profile and to provide strategies to support with integration of self-regulation into daily life. So here is a patient information leaflet that I've made on sensory regulation and functional neurological disorder, and it just goes through kind of how you're feeling, and it uses the zones of regulation to just find what's right for you. Now this can obviously some strategies to support with sensory regulation, and it's just about trying some out and seeing what works for you. But yeah, I think the red is something, it's maybe your disaster planning, Miriam, where it's like doing what you can do in that moment. So for me, before I came on stage, I felt really anxious. My heart was pumping as it should. So I just took a few minutes, I focused on my breath and did a little meditation in my head. So, you know, it's just about finding what area are you in and having those strategies that work for you and incorporating them in the moment. So as I said, I'm a sensory seeker, so in that moment I probably would have loved to have just run away. But yeah, I use those practical strategies to help. Then work. So if returning to work is one of your goals, we can explore what kind of work suits you and build skills to help you get ready for work again. We often collaborate with employers or write letters to support your return to work, if that is a goal of yours. And planning for the future. So as Roisin mentioned, before therapy ends, we'll help you put together a staying well plan. And this is a self-management plan to help you recognise and manage flare-ups, so you can stay well and continue making progress on your own.